This is an example from a very boring bit of the public sector in America called the Transportation Security Administration. They have an ideas factory where members of staff can come up with ideas, comment on other members of staff ideas. If such a boring bit of bureaucracy as them can do this, why doesn't all the health service have ideas factories of this kind? And here's a very different example, which we've hosted, called Social Innovation Camps, which bring together over a weekend usually about 100, 150 web designers and volunteers to design working websites to meet a social need. And this one you'll see at the top is one of the winners, which was a website for disabled people to work together designing products for disabled people. Very cheap, very fast, very effective at multiplying creativity. What's really striking out of many of these things is that most of the best ideas aren't in fact wacky and out of the box. They nearly always involve fairly, in some ways, predictable, almost incremental ways of thinking about things, but in quite sort of surprising ways. So, for example, inverting ideas. So you imagine patients becoming doctors, integrating in new ways, extending, differentiating, translating. I won't go through all of those, but just to say there are many quite usable tools which can help any group of nurses or doctors or patients quickly create much better solutions. You then have the challenge, how do you turn your brilliant ideas into things you can test, prototype, pilot, and so on. Again, very familiar methods in medical science, randomized controlled trials and so on. But in fact, many other kinds of methods, often of rapid prototyping, moving ideas very quickly into practice, simulating things, beta testing, open testing, and so on. And just to give one example from our own work, we've developed a number of roles called social entrepreneurs in residence located within PCTs and local authorities whose job it is to find and develop the really promising ideas and get them quickly either into a pilot or prototype or into a new social enterprise. And the first one in a university, Northampton University, has just been announced. It's a model of accelerating the innovative capacity of the NHS, which I think will spread pretty fast. Another example of a prototype which might interest some of you is one which we host called Maslaha, which came out of the problems many health services had relating to predominantly Muslim populations, and this service links together health expertise with imams advising on things like diet and diabetes in order to help improve health outcomes. But it's an example of the sort of thing you can move very quickly into trialing and prototyping without the full paraphernalia of RCTs. How then do you turn a good idea into something sustainable? Maybe one of the good ideas you were having about cutting loneliness a few minutes ago. And those of you who weren't talking to your neighbor, I assumed had such good ideas you didn't even need to talk to your neighbor. Here we have a whole series of tools, as it were, for assessment and selection. We have NICE, we have things like the Cochrane collaboration, we have NHS evidence providing data about what works. But there are a whole series of other tools for then turning something into a sustainable form. Some within the public sector, you make it a policy, you make it a guideline, you make it a priority. Some about creating new businesses or new social businesses, bringing together investment, professional commitment, and so on. This is an example from our social entrepreneur in residence in Birmingham, a new venture around mental health and teenagers, worth looking at if you're interested in that field. And it's a business model which now looks pretty sustainable, pretty scalable, because it is creating very direct value to the PCT. A more difficult but very interesting example comes from Canada called Ties, which brings sort of Facebook-type technology around a vulnerable older person so that the doctor, the social worker, friends and family can coordinate their visits, advice on prescriptions, cooking and so on. Its struggle in a way is to find who pays for that, who owns that as a problem, as a need. Is it the GP commissioning clusters? Is it the local authority? And can you turn that into a sustainable business model? Another very interesting example from our portfolio is called NeuroResponse, providing services for people with MS, using expert nurses and doctors, phones, video clinics, emails. Its challenge in a way is the more successful it is, the more it reduces pressure on hospital beds, which creates a bit of a clash of incentives for those parts of the NHS whose business models depend on having people filling hospital beds. And that's true of nearly all innovations. They will challenge someone else's revenue stream. And then there's a question of how you scale things, how you make them grow when they work. In some respects, the NHS is very lucky to have the power and the money to scale things very fast, and yet the constant complaint across the system is that good ideas stay only in one place. They're not adopted, they're not diffused, or it may take a very long time. It takes 8 years on average for nice recommendations to be fully implemented. Here again, there are many methods and tools for accelerating the scaling, the spreading, the replicating tasks. Some, again, through organizational forms like licensing or franchising, some through policy, some through investment, some through getting big organizations to take over the innovations of a small organization. There are interesting examples of rapid scaling in the past. Healthline, the first phone-based diagnostic service, was run in our basement, and then taken up by the NHS as NHS Direct, and then scaled very quickly with a lot of money as a new organization. Most innovations don't spread like that, however. This is another example which was developed mainly for hospitals providing language translation services. Again, from my organization. Now, it turned out this would scale best as a private company, getting access to private capital, and it's now actually owned from the US and is worth several £100 million, but it couldn't easily be scaled within the NHS system. And one of the questions I think we're increasingly going to ask in the health service is the question also of what is the best scale. And here I don't know if I can ask for a show of hands. This is a very simple chart looking at public services. The left-hand axis is efficiency, cost efficiency, from the least to the most, and the bottom one is smallest to largest in terms of size of organization. So, a show of hands, who thinks the basic pattern for the health service is a line going from bottom left to top right? That's to say, the bigger you are, the more efficient you are. Any takers for that? Nobody thinks big is beautiful. Okay? What about the opposite, the line going down like that? Big is inefficient, small is more efficient. Does anyone believe that? Does anyone believe anything about scale? Does anyone want to suggest what the correct pattern is? If you actually analyze the facts, you think it's a U, so most efficient in the smallest and the biggest, and least in the middle. Any other views at the back? Sorry, which one? That same? Yeah? You think it's a U, you think it's the opposite of him. So is most efficient in the middle, not very small or very big. Any other views? This is about the most important question for the health service. Which is the correct answer to this question? And I was very frustrated when I worked in government. I found that government constantly reorganized services, but never based on any analysis of this question. There was always an assumption either big was beautiful or small was beautiful. And so we did actually commission, oops, I missed the right slide, some research on what the correct answer is, and the correct answer is there is no pattern at all. None at all. You can be efficient, small, medium, or big, and anyone who claims otherwise is worth challenging, because it's the most common mistake made in public sector reform of all kinds.